So in a weight-bearing assessment, we can see that the patient's feet are quite severely pronated, and to measure or quantify the amount of pronation or supination, we normally use what is known as the foot posture index, which however has been amply dealt with in other videos. So at this stage, we can just take a look at the patient's foot, at the patient's feet. The left foot, there is quite severe hallux valgus with, as we said, axial rotation of the hallux. And we have also taken an impression of the patient's foot so that we can design appropriate treatment. And as one might understand, we will not be performing a lot of corrections in these orthoses because basically there is not much ranges of movement, and if we were to try to correct the patient's feet to get a more neutral position, that would actually probably cause more pain and harm to the patient. However, we know that orthoses work in different, using different methods by different means, and increasing the contact area and supporting the arch in this case might actually be of quite a lot of benefit to this lady.
So after casting the patient, here we are using another device, which is a handheld scanner, in order to get a 3D image of the cast. So it's we're obtaining a digital 3D image. Okay, so there's a process how to do this. Okay, by going around the object. In this case is the negative cast. Once you are happy with the image captured, you can send this to the design CAD/CAM software in order to start working on the design of the insole.
Objectives of the functional assessment which we will be performing on the patient will be to determine how function of the foot may be an etiology linked to the presenting pathology, whether the outcome of the treatment prescribed will be successful or not. Technologies indicated for this condition include pressure mapping, so we will be dealing with in-shoe pressure mapping and its application to a patient with rheumatoid arthritis. We'll be talking about 3D gait analysis and EMG or electromyography. Electromyography, or EMG for short, is an electrodiagnostic technique for evaluating and recording the electrical activity produced by skeletal muscles. Electromyogram is a record of muscular activity acquired using an electromyograph. Thus, electromyography measures the electrical activity that is responsible for contracting our muscles. Whenever we want to answer the question, what are the muscles doing, the benefit of EMG becomes immediately apparent. EMG allows us to look at the electrical activity responsible for muscle contractions and to measure muscular performance. Now, this is very important because most of the time, as clinicians, we tend to look at everything, at all the foot, the whole foot. We look at foot alignment, we look at joint motion, and we look at various other parameters, but we seem to forget most of the time that the muscles are the motive power behind the way we walk. So without proper muscular activity, our foot cannot function properly. So EMG will allow us to quantify this muscle performance And we can relate this to normal and abnormal activation of muscles. From literature and from our study of physiology, we know when the muscles of the foot are active. So during gait cycle, we know that the dorsiflexors are active during a certain period of time. So basically, the ankle dorsiflexors, which are those muscles which pass in front of the ankle, being the tibialis anterior, the extensor hallucis longus, and the extensor digitorum longus, are active at initial contact up to loading response. This is important because although the foot is plantar flexing at that moment in time, the dorsiflexor muscles are acting in an eccentric manner to provide a brake, a sort of braking so that the foot can be placed gently on the ground. And as we can see from this diagram taken from Perry, the dorsiflexors then are active in pre-swing. So during stance phase, we know that there should be no dorsiflexor activities. So during pre-swing, initial swing, mid-swing, and terminal swing up to initial contact, again, the dorsiflexors are active so that the foot is dorsiflexed in order to clear the foot as it is swinging to move in the air, to move in front of the other. So one way of utilizing EMG here is to measure dorsiflexor activity and comparing it to what we know from literature. The plantar flexors, on the other hand, are mainly active during stance phase. So these plantar flexors, which are the muscles that pass from behind the ankle joint, include the soleus, gastrocnemius, posterior tibialis, flexor digitorum longus, flexor hallucis longus, peroneus longus, and peroneus brevis. So their main activity is to push the body forward and provide propulsion during the stance phase of gait. So looking at published work, in this slide we can see normalized activity of a few plantar flexors. These are normalized to the gait cycle, and we can see the pattern of the tibialis anterior, the lateral gastrocnemius and the medial gastrocnemius, the peroneus brevis, peroneus longus, and the soleus. It becomes quite clear that once we have normative data, we can then determine whether our patient has normal activation or not. When an alpha motor neuron cell is activated, induced by the central nervous system or as a result of a reflex action, the conduction of this excitation travels along the motor nerve's axon, and neurotransmitters are released at the motor endplates. An endplate potential is formed at the muscle fibers and innervates the motor unit, which is the smallest functional unit where neural control over muscular contraction occurs. When an EMG sensor is placed over the muscle belly, it picks up each motor unit firing. So the raw EMG signal is a superimposition of multiple. We have many motor neurons which are firing together and thus forming one surface signal, which is a superimposition of all these signals together.